This study originated from the community. One of the women in the community came to us to talk about the need to do something about the stress women are going through hiding from people in their community because they have babies and they don't want community members to know. And so we use a community-based participatory research approach. This is an approach that actually creates an environment where women or those being studied become an active member of the research process. They take part right from the framing of the research question to the implementation of the different strategies of the research up to the end. The goal of doing a community-based participatory research is not only to create the transformative change that is needed, it's also to act as an education process. The investigation, the education, but also mobilizing community members for collective change. So we all become advocates to create the change that is needed. Through this kind of process, we establish mechanisms such as what we call CAG, Community Advisory Group, that met regularly throughout the 3 years of our study to actually advise us at strategic points to make sure we were engaging community to inform the whole process of data collection and even knowledge translation that has happened throughout. So through our integrated knowledge translation has happened throughout. We keep taking data back to the community to help us move it to the next phase, including having over 9 consultation meetings. In terms of design of the research, it was a mixed method research. So we did some quantitative surveys, standardized instruments that examine infant feeding attitude, motherhood, social support, stress scale, Cohen stress scale. We use all of these standardized instruments of survey to actually ask women questions about those different areas. But we also had the qualitative aspect, that's the focused ethnography, which actually involves studying like whole communities. In this case, we were studying the Black community to see how they experience motherhood in the context of this infant feeding. And so that has been quite an insightful experience, learning and going through this journey with the women. They told us their stories from different angles. They touched on many issues. They touched on motherhood and what it means to be a mother, how important it was for them, just the whole process of becoming a mother and having this baby and feeling a full sense of responsibility for this baby. And so that again really highlighted the kind of stress that women were going through. Here you have a baby, you want to do everything as a mother to protect that baby, but you also know that you're living with this virus called HIV, and you feel like, okay, so in the North American context, where you can feed the baby with formula and just feel, okay, I'm not infecting the baby, but then you have to deal with the cultural pressure. Why are you not putting the baby to the breast? What is going on with you? And so they're hiding. Some of them even move from where they live to live elsewhere where they would not meet community members. That became a source of stress for them. Then you look at a place like Nigeria, you say, okay, they are all encouraged to breastfeed, so they shouldn't face that pressure. Well, they have a different kind of pressure. They're breastfeeding, but at the same time, they're feeling the pressure that, well, I have this virus. I may infect my baby. I don't even have money to, or the access to get my medication on a regular basis. I'm not sure that my viral load is suppressed, so I may infect my baby. There's another source of stress. So you can see all of these dynamics happening. We need to address some of those issues. And that will start from the policies and the way the policies are implemented, the public education that promote breastfeeding as best for everyone without due consideration of those who are in position that may prevent them from breastfeeding. We need to target that, and we need to continue to generate research about the best models of practice that are available out there to address these issues for women. And because women do need support. It's not enough, I would like to add this, to give women formula and assume that all is well. Access to formula does not guarantee better mental state for these women. Some of these women are so stressed, they're actually dealing with mental health issues that just disrupt their ability to bond with their babies and the ability to provide the babies the best care that that baby can have. And we know that infant feeding is more than the nutritional uptake of physical like food, but it's more that psychological processes that happens, the bonding and all of those pieces. And if we truly want healthy children, healthy mothers, then we need to support mothers' own development of their mental state. And that requires not only giving formula, but also making sure that women receive the support they need. Social support was a key finding of our study to help mothers become better mothers, to feel good about their sense of motherhood, but also in terms of feeding the baby and taking care of those needs.